right, shall I just go ahead? I think we've given everybody some time to settle in if people join on. My name is Chris McAndrew, and tonight's AO Trauma North America Fellows webinar is on femoral neck fractures. We're going to focus mostly on younger patients and patients with higher energy injuries. That's me. I'm working in St. Louis at Washington University. Tonight on the panel is Jason Davis, an assistant chief of the orthopedic trauma service at Arbor UCLA in Torrance, California, and Jeffrey Earhart, also an assistant professor at Rush by way of working at Ortho Illinois in Rockford. Thanks for coming, guys. Really appreciate it. I hope you are all ready to jump right in, but we'll get a little bit of business out of the way. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. AO does not endorse nor promote the use of any product, service, or of particular commercial entities. And the equipment used in this course is for demonstration and teaching purposes. And the intent is to enhance the learning experience. Additionally, for everyone out there, keep your microphones muted and your video cameras turned off. Send all your questions to the Q&A box. The moderator will review and sort questions as they appear. And the use of the chat box is only for us to communicate. All right. We're here to talk about a few things. We kind of try to boil it down to 4 points: diagnostic details, surgical approaches, reduction tactics, and fixation techniques for the treatment of femoral neck fractures. These are our learning objectives. Again, to review, detailed diagnostics, mostly get into a little bit of use of advanced imaging, discuss open approaches for the reduction of femoral neck fractures with the pertinent pros and cons, share some reduction tactics and tips, and then talk a little bit about many different options, but a few that seem to get used most often in terms of fixation. We're already kind of going to catch up a little bit here, but here's our schedule, and it's pretty straightforward. So let's jump right in. So diagnostics in detail. This is a 32-year-old female who is in a motor vehicle crash and has a right femoral neck fracture displaced along with a femoral shaft fracture. And just kind of warm up the panel a little bit. Jason, anything jump out to you in particular about what's happened here? Dive right in.
Yeah, first thing that stands out is her what appears to be a large pannus fold right over the intended anterior approach that I would be thinking about pursuing in her. She has a very typical vertical looking high energy femoral neck fracture, oftentimes like we see here with a somewhat comminuted distal third femoral shaft. So pretty common presentation.
Awesome, thanks. So I guess, is this enough information to make the decisions that you want to make?
Yeah, no, I would definitely want a CT scan. I think that would better help me plan, look for any potential reads, any comminution, the fracture plane and obliquity that may help me obtain, maintain a reduction, and then eventually plan for fixation strategies. I think the CT is somewhat critical in better evaluating these.
We got a traction internal rotation view. Have I changed your mind?
No, I still want a CT scan for sure, but I think that is helpful. But CT scan for sure.
Yeah, I think it's a little bit of a additional, dynamic diagnostic for use, but I agree it can help you understand some things, but a CT for detail is a good approach. So I think kind of like you were starting to go down this road, and Jeff invite you in here. This is a CT scan of the same patient, and I don't know, does anything, jump out to you? And I can go back a little bit, and then, these cuts that are available. What are you thinking about when you see this CT?
Yeah, so the first thing I'm thinking is there is some comminution, and I'll be honest, on these cuts, a little hard to tell where exactly it's coming from. My suspicion is that it's posterior, maybe a little bit inferior, kind of classically, but it's a little concerning to me that I can't quite make out where that comminution is, and that may affect my ability to read on an open approach. And the other thing that I find interesting about this one is just how transcervical it is. It's a bit vertical if you measure out the angles by the traction view. However, it doesn't have that classic spike down into the calcar, at least not as prominently as you see in a lot of fracture patterns.
Yeah, I agree. I felt like this was close, maybe not quite, but seemed like a close representation of that relatively simple tension failure anteriorly, and a little bit of and not even that much, but a little bit of that inferior, and then going around posterior comminution as an example. And then wanted to kind of take it up to another case. Jeff, this is actually a 21-year-old undergrad who was on a renting one of the motorized rental bikes, and so he hit the ground pretty hard, but he hit the ground. So what do you think here, and what else do you want to know?
Yeah, I mean, there's something strange going on here. You could have fooled me with the age of the patient. So when you look at that left hip, this is more of like a Powell's type 1 kind of horizontal pattern, valgus impacted. But it's still concerning to me because there's that loss of an inferior hinge. It's displaced at the inferior neck, and certainly a decent amount of loss of offset and length in the leg. And the other thing that's kind of striking is just how valgus the right hip is. So, a little bit more of a history on this patient, why these bones look so washed out, why the neck shaft angle seems so valgus on the right, and yet has kind of collapsed down so much on the left. And I don't think it's much in the way of rotation. This is a reasonably rotated view of the pelvis. So I want to find out more about what's going on with this patient.
Yeah,
I think I'd be curious to find out this guy's history as well. His contralateral, supposedly uninjured hip has a very, like you said, valgus look and somewhat uncovered, like it's dysplastic. So curious to see what his history is.
Yeah, so it's nothing in terms of, we kind of quizzed him a bit on the nutrition side and the other potential chronic diseases side, and literally had no complaints, and was kind of young and vibrant, and was wondering why we're asking him so many questions. So he was that kind of guy, but did do a little bit of a look into things down the road. He didn't have any standout endocrine problems, but it is a very curious pattern, and in a young person. CT for me on this one is just something that, again, I think Jeff, like you pointed out, very important to kind of, in terms of making decisions about treatment of even valgus impacted femoral neck fractures, is that idea of, is it truly valgus impacted in the plane of the neck, or is it going to potentially be unstable and roll off the back? Certainly the sign of the loss of the hinge at the medial side is kind of makes you wonder. And but it does, like you said, the cross table lateral was okay, but this was kind of really not rolled off the back, truly impacted. But important details, because depending on how you want to treat them, an estimate of that stability is important. Same kind of looks, or same patient, sorry, different looks in the coronal cuts of the CT. How about this one? Maybe a little different, a little more exciting. Jeff, what do you think?
So this one clearly higher energy, and that's not just the vertical pattern, but just that displacement, that cranial migration of the femoral shaft is really concerning to me. So this is a femoral neck talk, but in this pattern, I'm looking for other axial injuries, just to remind everyone that we're treating the whole patient and not just the striking and scary injury to the hip in a young patient. Obviously, there's a lot of other injuries going on here, and so time's of the essence. But it's the comminution at the neck, and it's the cranial migration that worries me in this one.
Yeah, totally agree. Jason, anything that jumps out to you before I skip to this CT?
No, I mean, that in addition, he appears to have some sort of vascular access in his left groin as well. I don't know if that's one of those arterial balloons that you can inflate. But yeah, it's definitely a higher energy, and I'd be looking for other injuries as well.
Yeah, I mean, I think that's probably a very important takeaway point tonight. We're going to spend time about femoral necks, but femoral necks are all inpatients, so we got to take care of them first. As you might expect, this CT I think was really educational to me, and you know, she's a 34-year-old at this point in her life, and really high energy abdominal injuries, thigh compartment syndrome on the same side, and really, you know, pretty bad off. And it goes along with this, you know, because, you know, kind of talking about, you know, what are we going to do? Well, we try to save her life, but then we're also, she's pretty young, want to try to save her hip. But I couldn't find anywhere where I could expect to really get a good, you know, reduction read on this one. Looking back at it for sure, I thought I had myself convinced a little bit on the cranial anterior neck that I might be able to kind of piece you know, the simplest of the comminution back together, but this was definitely challenging, and you can see how much comminution and circumferential nature there is there. Same kind of idea with the coronals, and then a pretty good look when we have a, you know, kind of a way to rotate the patient in the gantry, you know, reformat and such, you know, that idea of measuring Powell's angle. I mean, you know, when you're talking about what forces are you resisting, it's, you know, sometimes even, yeah, I was surprised to find this one kind of, depending on where you draw the lines, beyond 90 degrees. So a real challenge. I think the points to make in this section really are that, you know, Corey Collins wrote this, you know, great paper. I can't remember, back a few years ago, 2014. And, you know, there are a lot of patterns like our first patient that, you know, patients follow. And so I think the relatively vertical shearing pattern, femoral neck, and a high energy injury with a little bit of comminution that's inferior and posterior. And then, as Dr. Earhart pointed out, the triangle or wedge that comes down slightly anteriorly, the base of the buttressable fracture, you know, that's the you know, standard pattern, if you will. But I've kind of grown to, this was exciting. I was like, okay, well, everybody I see then that's 35 and has a femoral neck fracture, it's all going to look like this, and I'm going to get myself a way to take care of that. And have kind of grown to appreciate what his group, or his, you know, going back to his old group, new group, wrote up in 2021 about how this is a little bit different. You know, there's it does stay around a you know, an average or a mean, but these things get a little bit more complicated. Point is, I think it's important to get a CT. I think it helps you a lot, even beyond, you know, your x-rays, to understand exactly how vertical these fractures are. Again, if you're going to open these, which you're going to do quite a bit, you want to know about the quality and the location of your reduction reads, and really make a detailed plan about how to attack that. Locate a fracture apex, and if you can interdigitate that inherent stability by itself does a lot more for helping your implants than anything else. You can measure the length of the head segment and kind of know what you're getting into, especially if they're a little older or the bone quality is a little worse. And again, know where the comminution is as well, so you can plan which implants you want to place where to resist shortening. I think, interestingly, thinking about advanced imaging, this idea that we still have quite a few missed femoral neck fractures in the setting of femoral shaft fractures, like our first patient. The Houston groups brought this idea about having a limited MRI scan. It's very intriguing, and we've kind of talked a little bit around it at our place, but we haven't gotten into it yet. Have you guys tried this yet? I think this is, you know, pretty phenomenal idea if you can logistically make it happen.
We have difficulty even getting the patient up to the OR in a timely manner or getting turnover, although it's a great idea. I think what's striking about this paper is that using the CT protocol, they identified 7%, I think, femoral neck fractures associated with shafts. That more than doubled when they included the MRI. So has me somewhat concerned, like, wow, I mean, there really are more out there, maybe twice as many as we think. Sure, in the paper, they demonstrated that, the majority of them were incomplete, but I mean, you'd like to know to stabilize those and prevent them from becoming complete. Just to your point, resources, can your facility tolerate that?
Yeah, I think we could get into a whole discussion too about how you nail the femur and what kind of nail and screw design you use around that as well, but we'll save that for another fellows webinar. All right, let's move on to surgical approaches. Anybody who's out there, we do have a polling question. What is the preferred surgical approach for open reduction and internal fixation of the femoral neck fracture? I think that's certainly a reasonable response. I think it gets a lot of traction, and we'll talk a little bit about it. It is a little bit of a attempt at a trick question in some ways, because I think the Smith-Peterson and the Hoyter, or however you want to say that, go quite closely together, and that's a whole nother talk too. But the Watson-Jones, certainly a little bit more of the old guard. We'll talk about using the Watson-Jones. Throw the surgical hip dislocation out for femoral necks. All right. Let's see. I think, Jeff, you know this case the best, but this is a 24-year-old motor vehicle crash, hemodynamically unstable. Very similar to the patient we showed third in that last little bit, but basicervical neck, ipsilateral shaft, multiple other injuries, but importantly, not necessarily doing great on the first night. And I think, if I remember, has an X-lap. So lots has been happening to this patient. And I think here's our next polling question. This is another good launching topic. What should be done acutely the night of the presentation? The patient's had an X-lap and they're in the operating room and the consult's been made. What should we do for the femoral neck fracture? All right, we got some results. All right, traction off the X-fix frame, and nothing would be kind of a little bit, wouldn't make you feel great, but sometimes it's got to happen. Again, it's life before hip, but closed reduction percutaneous screw, open reduction full bore. Jeff, what are you thinking?
So I'll be honest, this isn't my patient. This came from a friend of mine in Chicago, and I'm sort of with the two that voted for hanging traction off the X-fix frame. And I think it just sort of depends on how the patient's doing in the OR and how quickly you can do anything else stabilizing. The goal of care the night of is truly to stabilize. It's not to make it perfect. D is absolutely inappropriate in this clinical setting. I think A is also inappropriate to leave that hip completely unstable. So really it boils down to B and C. And I have a few colleagues who I've talked to in the past who will try to get just a cannulated screw, just one, sometimes two, with a reasonable close reduction when they anticipate a long delay to return to the OR. And I think that's what it boils down to. I don't think it's a good idea to stick a bunch of screws into the neck without an acceptable reduction as a matter of routine. But when you have a patient who's unstable or an extremis and you don't know how long it's going to be until they can go back and they have all sorts of nursing care needs, something more stabilizing like a screw might be appropriate.
I agree. Jason, any thoughts?
I agree. I think it's just, you got to save this person's life and I think do something, stabilize the femur in some way. But to get into long open reduction internal fixation of a potentially complicated femoral neck, not the right time. But if you can obtain a closed reduction that looks pretty darn good, I don't see anything wrong with putting a single screw, then evaluating later, maybe getting a CT scan to check your reduction before you move forward.
Yeah, I think the other side of this too is the downside, which I've unfortunately experienced with the nothing or even with traction off the X-Fix is, you're going to lose some of what you have, in terms of soft tissue tension over time. It's going to make things a little bit harder to get out to length and kind of make use even over a couple of days. But sometimes a little bit of this read or that might be impacted by the time you get there too. So I think a little bit of something goes a long way. And that's what they did. I mean, I got to tell you, that's a bang up job. Jeff, what do you think?
I mean, it's pretty unbelievable. And I called Ben directly and I said, what did you do? And he just traction internal rotation with one of his residents, and it lined up really great. I mean, this is, it's not an appropriate definitive construct, but man, that reduction is pretty amazing. So it doesn't have to be this perfect the night of. It just has to be reasonable and stable. And this is pretty incredible that they were able to achieve this in light of everything else going on that night.
Yeah, I think the curious thing about this case too then is, so what do you guys do? You've got this situation. Things look really good on fluoro. Like you said, this is not the long-term solution, certainly in terms of fixation, but how do you evaluate then? What do you guys do? Jeff, I'll let you go first.
Yeah, I mean, I think, with this pattern, this relatively simple looking pattern is begging for an anatomic reduction just to be a little bit more load sharing in the end. So this gets a CT and you want to really just critique critically the reduction. I mean, this looks great, but you can be surprised, missing comminution, subtle displacements that you may have missed. And if it doesn't mean that you're necessarily going to have to convert to something open, but I would use a CT to critique the reduction before I just accept it as the definitive reduction for this.
Yeah, I like that. Jason?
Totally agree. CT scan, and I think we know where this is going, where we discuss closed versus open, but this is the one that if you can get that closed reduction in the OR, I mean, literature now would suggest that it's permissible, or I mean, we can at least attempt it or think about it. I've always been hesitant. I don't have a lot of experience with closed reductions of femoral necks, but this looks pretty darn good.
Yeah, I like it. I think the getting a CT and really getting critical on it, and even where this screw is exactly in space can be very helpful too, right? So if you recannulate that when you go back, and that guide wire is exactly here, and I can map out exactly where I want to put any other screws, that might be useful. But yeah, again, same deal, kind of going back to the previous conversation, really be critical about how stable is this, do you think, and does it need more? And so I think that was the decision that was made. Just to run through really quickly, the Smith-Peterson and the Hooder. Jeff, you'll have to tell me how I'm mispronouncing that, because I never really know. But,
I'm with you.
But anyway, the description and the ideas, the thoughts behind this is, imagine again, you're a little bit more onto the proximal part of the hip, and you can expose probably a little bit further, certainly onto the femoral head, a little easier than some of the other options. And so also gives you kind of a working space directly down onto an anterior fracture line. The downside, at least, people will cite, is that you make a separate incision for your implants. And depending on what those implants are, that incision may not be much of one, or may be something real. So something to think about. This is kind of what you get when you look at things, and having, again, because you're looking directly down on the anterior neck, and if you've studied the CT and you've got an anterior read, you're going to want to make sure you've got modified clamps, or sometimes screw-based clamps can be helpful to manipulate this, and we'll talk a little bit more about that kind of stuff. The Watson-Jones is, like I said, I feel like most of the time when we bring up which approach, I feel like the Venn diagram is somewhat older surgeons are used to using this a lot more than some of the younger surgeons in the room. that may not be entirely the case. I think this is nice, especially as you get further down on the base of the neck, or if you're wondering if it's an intertrochanteric fracture or a basicervical fracture, it might be the right one, because the upside down T, or the capsulotomy you're going to make from the bottom up here, gives you access a little bit more caudal on the neck, but it's going to be a little bit harder to get further proximal. And for me, I've personally used the Watson-Jones when things are minimally displaced and more caudal along the neck, and tend to stick with the Smith-Peterson or Hooter for most of the femoral necks I'm fixing. How about you guys?
Jeff?
Yeah, I have no personal experience with the Watson-Jones. I find, for the handful of cases I've had in my time out here, a direct anterior approach and approaching that anterior cortical read has been the most helpful for me. So I can't speak to this approach personally.
Same. I prefer the direct anterior. I think for number one, that's how I was taught, and I just, for how I like to use clamps, just the coming straight down on top of it, just I'm more comfortable with that reduction style, being able to palpate and see everything. The question for you, Chris, when you do the Watson-Jones, what are you doing with vastus lateralis when you do apply your fixation? Because that's the one thing I hear people taking it down anteriorly as a sleeve, taking it off entirely, then repairing it at the end. Because I think if you're just going to do screws, the Watson-Jones doesn't have as much of a benefit. If you're going to apply a lateral sided, sliding hip screw construct, okay, it makes sense, but then you still have to get around vastus somehow. So how are you doing that?
Yeah, I think it does kind of depend on what the what the fixation is going to be, and I think also a little bit of who the patient is. The younger the patients are, for like the purposes of what we're talking about tonight, I like to take kind of the at the ridge and leave a cuff, and really kind of you take, it ends up being quite a bit of the vastus off its origin and going anterior, because that's continuing up into this approach. So it does become a little bit of a takedown of the vastus there, but I think done with kind of that repair in mind on the way in, especially, you can really get some pretty good repairs. And even sometimes, if for certain situations where you have to put a plate that goes up onto the trochanter, if you save the cuff in a way where you can bring the vastus back over onto the posterior corner of its origin, can also be useful. But yeah, it does become a little bit more of a thing. Like you said, I think that's a great point. If you're just going to use cannulated screws, this whole argument of 2 incisions kind of goes away. And so, but it is most of the time for me associated with some kind of side plate device. And that's ends up being a little bit more vastus takedown, but a thoughtful repair. Yeah, I think, like we were talking about, this becomes a little bit of a different orientation in terms of applying clamps. And so, you can get quite a ways over, but these are, not exactly blind, but fluoroscopically guided sometimes clamps. And they may be intra-articular, but they may also go extra-articular and pull things over. But you're not kind of, quite as close, like we're talking about to seeing the action and kind of being able to load it. So you can get clamps pretty deep through this approach, but you can't necessarily, really be, as maybe precise as, at least in my hands, as you might in the anterior approach. So I think, going back to this case, what kind of surprised me was they had this and, CT'd it up, gave him a week and got a lot better, which is, a great situation for him. But, when I was looking at the injury film and the fluoro spots, I was thinking for sure this is going to end up being Smith-Peterson, and this is kind of like where this is going eventually when they get back to it. But Jeff, any insider tips? And maybe you guys already talked, or maybe that we've already talked about it. Why go with the Watson-Jones here?
Yeah, I'm not completely sure the rationale. I think part of it was the ability to extend a little bit distally and do some direct manipulation of the femoral shaft at the same time. And I think some familiarity from training, but yeah, I don't think there's a wrong answer. You have to do what you can do best. And yeah, I was kind of surprised too. What really surprised me was doing this whole thing lateral. I've done a few retrograde nails in the lateral position. It's pretty cool. It's hard, and then you throw this approach on, and to me that was that was an interesting choice, but it worked. You do what works.
Yeah, I think that's why I like this case and wanted to include it a little bit because, again, I was jumping to my own inherent bias, I guess, in a way. I was thinking Smith Pete all the way, and then like we brought up, the side plate issue is one. Being able to manipulate the femur, proximally is another, and you can see to that fracture line. A little bit. I think you can feel quite well there, but you can see it and you can clean it. So I think that's, don't throw it out. It's still useful, Watson Jones. All right. Reduction tactics. This is where the old tips and tricks come in, as they say. For a case, we've got a 32-year-old with a right femoral neck fracture. She's got some posterior calcar comminution, shortened and kind of a short segment. So let's see what we've got in terms of further stuff. Just keep this one in mind. We'll go back to it a little bit, but when you guys see this first image, again, we talked about it, CT, getting some understanding of what exactly this is going to entail. But, is there anything that jumps out in terms of what you're going to want to have ready, like the old, what am I going to call for? What do I need? Jason, anything come to mind that you want to make sure you got the team getting out of the closet for you?
Yeah, I think you highlighted how it looks pretty short. So, previously you showed a traction view. This is one where I wouldn't mind seeing a traction view. It even, based on the history, it sounds like it's acute, but it has a funky appearance. Like if it were a different clinical scenario, I'd question if it's acute. The reads don't look all that great either. So I'd be prepared to provide some type of length, either with skeletal traction off the bed, resident, or even some type of screw-based clamp that could really give you the length of manipulation that you need through direct anterior approach. Assuming you're going to open to reduce it, which I think I probably would, but I would need some more information.
Jeff, any ideas?
Yeah, I think this is a great case where a traction view, just to help your mindset going into the case, would be helpful. I know we get a CT on most of these, and you get a lot of really good information from the CT. But for me, going into the case, knowing how this is going to respond under traction is very settling when I'm planning these out. So I would want to understand the pattern better in a traction setting before I would go in. And then just from the looks of this, it looks to me, to the best I can tell, that although it's fairly vertical, I'm anticipating comminution, and it really almost has like a subcapital to transcervical kind of orientation, which is really unusual. And so I know this isn't going to really play nicely. And so for me, I'm calling for lots of K-wires. Like, I just anticipate a very unstable situation. Even if I do have a read that I can clamp, that's only restoring anatomy. And I'm anticipating the need for a lot of provisional fixation in this before I go to anything definitive.
Yeah, I like that idea. Even if you have a read, but if it's precariously balanced, and if you're doing the old assistant, oxygen consuming traction, they get tired, right? So you got to be ready to load it up with some temporary stuff for sure. All right. I think, in terms of, getting reductions, it's very tempting to kind of have a wide exposure, right? And I think Jason, in our kind of preamble for this, brought this up, and I think I want to reiterate it too, even on both the superior and inferior side of the neck, right? So starting off, you want to do an approach that is going to allow you to see things, but you don't want to damage certainly the blood supply of the femoral head. But as we'll talk about a little bit later, maybe there's something to think about in terms of just the blood supply in general to the femoral neck. And so respecting the superior retinacular artery and the inferior retinacular artery, they come with different names. So careful placement of retractors or use of just right angle retractors and assistance is going to be key. So I'll tell you, this is one of those situations where sometimes you're on call and your number of assistants goes down a little bit. You got to pay attention to these things. So in terms of reduction tactics, and I don't mean to sound facetious about it, like these are cases where you're going to need more than one person to help, because you don't want to be relying on somebody half paying attention with a Homan or a hook type retractor on something, getting things done. The other point I want to make about reduction is they are kind of precarious. And so it's really smart, if you ask me. So I can't remember who showed me this the first time, but if you can get provisional fixation loaded up and ready to go for these things that are hard to manage, hard to hold, hard to manipulate, if you have traction, pull, internal clamp, everything else, and it's going good, you don't want to wait for the tech to go, oh yeah, you need a wire, and turn back around and everything else. That's another one of those assistants. You may be the person with your hands on the clamp, and it's just, you can't click it another time. You have to kind of keep your forearm pronated a little bit. You're just leaning on it, and somebody can help you by just putting that wire in, right? And so have those loaded up and ready to go before you get that reduction. For the Smith-Peterson approach, like we were talking about, I think this is a great slide where, modified clamps, and if you can get modified clamps too that have different size or different kind of apertures, extremely helpful. So this, we call this a bulldog. It's been modified, but a bulldog at our place, kind of a small pointed forceps, but a long handle. As you saw some of the other slides, it might be more the medium-sized Weber that's been modified, but straightened tines to go into drill holes or drill-based clamps. On this slide too, the Chance pin in the shaft is very helpful. And I'd say, you got the K wires into the neck. Jason talking about getting that rotation just right. I've also used, it's a slightly bigger hole than I, sometimes wish I made, but a 4.0 Chance pin can be a good tool too. But the K wires you use, they need to be, not so bendable. They need to be able to do something. So any thoughts, guys? Jason, what do you think about any other stuff before we go on?
No, those are all very good points. Just be prepared for everything. And it's my favorite clamp. I call it Goldilocks, not too big, not too small. But it's a very good clamp application through some 2.5 millimeter drill holes. I do like the large pointed tenaculums as well. You can do the modified or straight curved and different orientations. Real quick though about the Smith-Peterson, and on the previous slide you showed the Homan over the superior neck, and I think this is an approach that I admittedly struggled with early on. It's an approach that it's not terribly difficult, but we don't do it a whole lot. Maybe open knees like a handful of times a year. And so it took me a while to kind of get comfortable with getting to where you want to be, seeing what you want to see. So I would recommend going maybe big at first, a large incision, use fluoro to identify where exactly you want to make your capsulotomy before you make it. And maybe consider taking down rectus tendon too to improve your exposure. I don't do that routinely now, although I did a lot early on. All those things are helpful to really get comfortable with the approach, to see what you want to see so you don't start throwing Homans where you shouldn't be, just to struggle to get the visualization.
Jeff, any other thoughts?
No, I totally agree. I think, the Smith-Pete, the Hoyter, whatever it is, approach has sort of become a staple in training because of the direct anterior total hip. But this is a different ballgame. This is, traumatized tissue. These are young and muscular patients, not old and frail people. I mean, it's a struggle, and it's really tempting to throw those bent Homans, over the neck and under the neck, and it is very tempting. You can't do it. You have to, judiciously extend your incisions. I totally agree with the rectus release. I think it's critical in these young muscular patients to see correctly, it's just not the same approach that you're doing in the geriatric total hip situation.
Yeah, for sure. All right. So the modified clamps or the screw-based clamps, the Young Bluth, These are available for both 3/5 screws and 4/5 screws. I think the old classic that's on the pelvic reduction sets for 4/5 screws, and that's probably too big for what you want to do in the femoral neck. So make sure you got the right size. Farabuff would be a useful one, but a little bit less control, like we were talking about, being able to distract, rotate around, and even admittedly make up for maybe not perfectly placed screw before you put it on. The Young Bluth has a little advantage over the Farabuff. Yeah, going into the Watson Jones idea, again, pay attention to where you put these clamps, and don't spend a lot of time continuously digging or trying to get a little bit further around, particularly this one on the cranial neck, right? I mean, this is a little bit of a danger zone, but pay attention to where it is anteriorly, and don't go over the top of the neck on that cranial part of the reed. If you're using this through the Watson Jones, it's a little harder to see where you're at, and it can be down and around the neck, getting towards the piriformis fossa before too long. You can get pointed or collinear clamps that go over the front. Also a pretty useful thing through the Watson Jones for me. The collinear clamp, you got to be careful. I think you can see on this one, this is even, going into her vastus ridge. It's pretty powerful. And if it's not, finishing the deal for you and you squeeze a little harder, you might find yourself got a big hole. All right, so back to our case though, 32-year-old posterior calcar comminution. Let's see what happens. Oh, surprise. We're going to talk a little bit about this idea of the closed reduction. And I think this, first of all, I think all the closed reductions, the old papers about the proximal humerus, certainly going back through the Ledbetter maneuver, some of the history is not only is it informative just about where kind of we've been as treating surgeons, but also it's practical. I mean, some of these things can actually help you get the case started. And, even if you're going straight to an open reduction, knowing some of these little kind of tricks of the trade from the old times can help things kind of get unlocked and get most of the way. And then you're just fine tuning the problem, right? So as we kind of see here, flexing and trying to put a little bit of traction on the hip in line with the neck while it's flexed and the capsule is somewhat relaxed, and then circumducting and bringing the hip back into extension while maintaining that internal rotation. It's really kind of classic closed reduction of fractures, right? Doing a little recreation, doing a little relaxation of the soft tissue tension before manipulating and trying to get the reduction that you want. And I think it's an important thing to remember. I'm not sure you want to internally rotate 90 degrees on the traction table like the diagram has here, but a little internal rotation would be good. You guys have any thoughts, any uses of any recent kind of Ledbetter stories, if you will?
Unfortunately, no.
I mean, the hard part is once you reduce it, how do you keep it reduced while you apply your fixation? If you're throwing it on a fracture table, holding it there, I guess, but I know what the literature says, and I want to try it. They say it works, but I'm scared.
I've tried it a couple of times, and it's like you said. I think this is one of these things where, the old papers that talk about stability of fractures, I think these guys paid a lot of attention to that, right? And they learned the hard way, kind of like we're afraid to, or kind of we have anticipatory fear, right? Like, oh, this is going to be unstable. I'm going to do this, and then it's just going to fall apart again. Some of these will, right? I mean, I think maybe the case from earlier with the polytraumatized patient in the X-lap, that might have been, there was some kind of, grace of the orthopedic gods there, right? So this patient does go for a closed reduction, probably based to some degree on the comminution. I think, Jason, you know about this one?
That is not my case. Although, if that's the closed reduction, I don't think you can argue with that. And you can sense my own struggle with the closed versus open reduction literature that's recently come out. And because, I think like maybe all of us were trained in an era where, to do a close was somewhat like, you can't do that. It's a big no-no. And now I think with the literature, while we have maybe permission to attempt a closed reduction, certainly we don't have permission to accept a poor reduction, or permission to take somebody to the OR not prepared to open if we don't get an acceptable reduction. But this looks great. I think with femoral necks in general, it's such a unforgiving fracture, and the salvage options really alter the anatomy and are not benign. So I hesitate in accepting a less than perfect reduction, and fluoro can somewhat trick you, but this looks great. It really does.
Jeff, thoughts?
Yeah, this was my case with my partner. We cover a smaller level 2 community hospital. This was a 32-year-old, and we went in ready to open, and there was a reed anteriorly, but there was also a little chunk of calcar comminution, which was concerning. And so what the combination of those things did is we put her on the table, we pulled and rotated and got this reduction, and the calcar looked good. And so really the comminution drove our implant selection more than anything else. But yeah, I think if you like Jason said, if you get a good reduction, that's the goal, and it's not benign to open these people up. So in the absence of like a truly simple, clean fracture pattern that's going to be more load sharing, I think this is the way to go.
Yeah, I think I agree. I think that idea that the open approach is not benign is the truth, and one of my mentors told me once, when they start telling you that, surgery isn't benign, it doesn't mean that you have to stop doing the surgery. It means you have to get better at it. So there is a little bit of that, right? And I think that's what we're all here to talk about. But absolutely, closed reductions and taking that to the next level is certainly where some of the conversation is. And I think improved imaging, maybe even intraoperative, kind of being able to get some of these things and confirm some of these things with 3 dimensions is potentially going to take us even further there. But I also think, like you said, this is an expertise thing. And I think the same people that are prepared to open it up are the same people that interpret those fluoros and kind of understand the injuries well too. So, I think always be prepared is a good idea, but maybe these closed reductions work, right? This is some of the literature we're talking about from Joe Patterson out at LA now. Pretty troubling kind of non-union numbers, right? What do you guys think?
I think it highlights that this is a difficult problem, and it's it's a problem that occurs on a spectrum. We can classify morphology, we can study CTs of fracture patterns, but there's a biologic hit in these that we don't completely understand and we can't completely stratify. And these patients just don't always do well. It's crazy to me, to see this. And in the paper, the assumption was going to be the opposite when they went in to do this analysis, and they found the opposite of what they expected. We don't always know, and this is a very challenging injury.
Totally. I think, no longer can we operate under the dogma that you have to open them all. And that's something that I'm still trying to figure out how to navigate that. And I think Jeff made a good point about, if it's one where you're not going to get a great read open, maybe I think it falls on both sides of the spectrum. If it's so simple and serrated that you think you can key it in closed and it looks great on fluoro, great. On the other side, if it's so maybe comminuted, inferior medially or posteriorly rather, where it's not going to be a good key or a good read, maybe that's the one you could leave the biology alone, restore Shenton's line, apply your fixation, fixed angle, give it some robust stability and go for it.
Yeah, I totally agree. I think the many more chapters are right here, but sometimes you got to be honest with yourself. Can you make it better if you're looking right at it? And that's where those CTs come in. So this is another polling question, keeping the couple of you out there alive and awake. When should you consider a closed reduction for femoral neck fracture? All right, good. Our trick questions have kind of finally broken the ice a little bit. But yeah, I think these all have, some, legitimacy. I totally agree. And for the basal cervical one, I think we think about this kind of classic one with a really good read that we can really kind of set and load with a clamp. And sometimes maybe that's the one where, like, if you get it closed and it has some inherent stability, I don't know. I'm still going to probably open that one. For me, it's been the, sadly, some of the ballistic ones or the circumferentially comminuted ones that you just don't think you can make better with an open approach. Again, just ideas behind this and repeating a little bit of what we're talking about. But this non-union question, I challenge you guys to think about it. What is the role of the lateral femoral circumflex artery and kind of those ascending branches going into the capsule? They really peter out, but they do feed that bone around the front. And so maybe, again, love to talk to you guys about it at some point down the road. Hopefully somebody explores this and understands it better than I do. I mean, Dr. Rout talked about it a little bit, and I think there might be something to this, and maybe I just didn't get it out of him the last time I talked to him, but, mind the lateral femoral circumflex as well. All right, we better hustle along, but let's talk about fixation techniques. Everybody likes metal, right? So what is the ideal femoral neck fracture fixation construct for a basicervical fracture pattern? Another polling question for you guys. Hoping to divide all three of you separately. That'd be great. Oh. All right. Certainly some sliding hip screw fans out there. What do you guys think, Jason?
Yeah, I think a fixed angle construct is nice, particularly as you get more basicervical and particularly extracapsular. Absolutely. Yeah, but I like screws though. I'm a big screw fan. I think Scalero has a great biomechanical study recently where the screws actually outperformed the sliding hip screw. So, yeah.
Jeff?
I've migrated, in my practice away from screws and towards the sliding hip screw for the handful of these that I've done. And I reserve screws at this point really for that kind of non-displaced, the neck shaft where there's like that vertical crack in the bone, and maybe you don't want to go in and open up and do like the whole sliding hip screw thing around your nail. I think screws in that situation are great. But for the ones that I've had, most of them have some level of comminution. I've had a couple that were circumferentially comminuted, and to me, the construct is like hanging a hat on a hook, and that's it. And so having that fixed angle is sort of the last prayer for maintaining a normal neck shaft angle. So I've gone more towards sliding hip screw in most constructs outside the non-displaced neck shaft.
Yeah, I agree. If you need something that's going to resist shear because there's nothing inherently stable at the base of the neck, I absolutely agree. This is a 35-year-old who fell from height, and there's a long list of reasons why I could tell you, but sorry guys, I don't have a CT, but this is the best thing we got. So, traction already in the operating room, and, with this much displacement, I was kind of thinking to myself already, I'm not sure what kind of reduction I'm going to get. And this isn't a bad start, but I just couldn't, lock anything in for sure. She's going to get an open approach. Thoughts here? I mean, is this a little too proximal for the sliding hip screw? Are you worried about things rotating? Anything else you might, think of using?
Certainly an anti-rotational screw, but this very high energy vertical fracture pattern, I think would do well with a fixed angle device, something to resist that shear.
I've been at times left dissatisfied, whether it's in the extracapsular world or the intracapsular world with the single anti-rotation screw. And so I've, in this kind of a situation, shifted my thinking more towards an inverted triangle, except the Calcar screw is the sliding hip screw. And I think that's a really nice way to have 3 points of fixation in something like this, starting with the guide wires, maybe one of your anti-rotation screws, having your guide wire for the sliding hip screw in place, and then having those 3 points kind of controlling rotation as you're advancing your implant. So I've stuck to the modified inverted triangle in this setting.
I like it. I like it. I think when we start talking about implants, the other thing we got to talk about is what is the goal. And we've gotten a little bit into this resistance of shear, particularly when there's no inherent stability. And so the sliding hip screw at that angle fixed is not going to bend. It's not going to rotate around a point on the lateral cortex like a cannulated screw is key. The typical kind of failure, or the typical displacement is varus and apex anterior. So think about it in 3 dimensions as well. If you're going to load something, you might think about compressing on that side. And if you want to strut out some comminution or maintain some length where things are going to, compress, maybe some posterior fixation that's fixed to length. I mean, it's another debate we could go on and on about the, do you ever use the fully threaded or something that resists length? But even when you're talking about cannulated screws, I think it's really important to talk about where which one gets put and when and how. And again, a little bit of inferior and posterior comminution can be expected, and thoughtful placement of a fully threaded screw after you've put a partially threaded screw to load that kind of anterior inferior quadrant, I think is a good idea. This is a great case of Jeff's that highlights the use of a Powell's, kind of a modified Powell's look. I love this idea, even, adding some, using some slightly smaller screws, maybe not available back in the 70s and 80s when people were talking about this as much. But Jeff, what drives you to do this? What's a good case for this one?
Yeah, so, Powell's is effective through, generating intrafragmentary compression. That's how you resist shear. So there's no inherent anti-shear ability to this construct. So you really want to optimize, obviously, first your reduction, and then you really want to generate as much compression as possible. So the classic Powell screw, which is essentially a unicortical screw going into the inferior head, perpendicular to the fracture, and in young good bone, you can generate pretty good compression that way. The idea here is that, you can engage that really strong inferior neck kind of calcar bone with a screw when you go bicortically with a smaller screw, and sort of sneak that into an otherwise, standard inverted triangle construct, and really generate a lot of compression that way, and, in that way resist shear.
Yeah, I love it. I mean, I think this is, very elegant example of that. And I've always kind of wondered about that unicortical use of that, the old school way. But the times I've done this, it's been bicortical, and then you're kind of, mixing things, I guess, using cancella screws sometimes. But I think it's important to get that other cortex, and it's extremely useful. Again, like Dr. Earhart said, the idea that this reduction has to be kind of to some degree clicked in, because that's, the resistance of shear in this situation, still cannulated screws. But if you've generated that compression and you've got that reduction, that's a really elegant way to make use of inherent stability. The sliding hip screw, like we talked about, sometimes around a nail, anti-rotation screws, a little bit of, leftover gap up at the top there. I think I might have done a little bit better in terms of compressing there, but, resisting shear, and remember to do something to avoid rotating around those big threads, especially if you're taking care of somebody young. If you haven't tapped, especially, but certainly even when you have tapped, the lag screw and the sliding hip screw can rotate the femoral head around and maybe even tear away the vessels. One of my mentors in fellowship pointed this paper out to me, and it is, at the time, might have been some of the better results from taking care of femoral neck fractures. I've only done this once, and it was probably truly somewhere between basicervical and intertroch. The problem with this is it certainly resists shear, but you've got to generate compression on the front end. So it's the kind of thing, for me, this has got to be like open reduced and really squeezed. And then sure, I mean, I don't think very many people are going to walk their way through a blade plate, but this might be the ultimate resistance of shear, but you've got to compress before you put that thing in, and you got to be able to hold it. I don't know, there's lots of new stuff out there, right? The femoral neck system, and I think this is called the Conquest. Again, no sponsorship here, and the faculty on tonight, all admittedly have limited to no kind of experience with these things. I'm still looking for the right patient for some of these things. I feel like this is somewhere between the younger and older person for me. I just, maybe it gets a closed reduction, maybe it gets an open reduction, but something you just think their bone quality is not quite as good as most young people, and you might, need some extra support and some extra, anti-rotation or length kind of in the long term. What are you guys' thoughts on these things? Jason?
Not a whole lot of experience with them. I tend to agree maybe in the elder patient. Otherwise, the one that doesn't have the threads in the barrel, you have to make sure, to your point, you compress it first, because you're not going to achieve any compression necessarily with that implant. That's my concern there, but fixed angle.
Yep. Jeff?
I think we're still at the stage where the jury's out and it all comes down to the reduction and, the principle of resisting shear and having a fixed angle device is there, but the jury's out.
Yeah, totally agree. When you've got something that's impacted, if you're trying to resist the loss of length, right? You're trying to maintain that offset. I mean, this is an old paper of Dean Lorich's, so think about where you want to maintain length, and the fibula in his argument is something that's more durable than a cannulated screw that's fully threaded, because in theory, there's going to be some kind of biologic growth into it as opposed to kind of erosion around it. So yeah, propping it up or supporting that posterior inferior comminution, at least a thought. Surface implants, I think this is one of these things these are a couple of my cases, and I think the buttress plate on the kind of anteromedial neck is one that gets some attention and people talk about it. It looks pretty cool, I guess, in some ways. The anterior plate, the tension band plate, was actually one of the first things I had kind of tried. And they talk about in some of the older papers that make quick mention of this, it can be kind of temporary or permanent. I'll tell you, if you put it on the anterior neck and you use a 3-5 plate, their labrum isn't going to like it. So this guy ended up getting the plate out. So what we do with the 35-year-old who fell from a height, again, very little information, but she did have a little bit of posterior comminution, but not very much. This is kind of like a little bit of that classic, maybe a little bit higher fracture vertex, a little more proximal than some, but pretty crisp reads. And so she got an open approach and loaded up with the Young Booth clamp wires and then cannulated screws in at first. And then it allowed us to kind of rotate the hip and build something that was going to, resist the shear. It was pretty durable because, we found out the hard way. She was kind of walking into the ER without her crutches, unfortunately, a couple of times, but seems to have lasted at least as long as we had follow-up with her for 10 weeks in the ER. So, it's a pretty useful, again, shear resisting kind of implant, and can be used with the cannulated screws to kind of do some of the other things you want to do in terms of loading fractures and resisting some length loss with fully threaded screws. You guys have any thoughts on surface implants? Any tales of glory or trails of tears?
I don't have much experience with it. I think that's an awesome construct. From what I've seen, their plating applications tend to fall into two categories. Either it's a sort of temporary stability type construct, and then you apply something definitive afterwards, or you have something solid fixing it initially so you can rotate the hip enough to get that plate there where you did, which is an awesome position. I think the biomechanical study that suggested you have increased stability, they have it really low and inferior on the neck, and rarely do I see plates in that position, although this application looks like you got it. It looks awesome.
Thanks. Yeah, I think, I definitely was enamored with it, and maybe we'll have to come back for round 2 of, how it's failed, but it goes back to our first section, study the injuries and kind of understand that kind of stuff, because they're not quite as all the same as that 2014 paper made of sound of these. So
hey, Chris,
anyway,
can I ask you
yeah.
one question about that? In the setting, if there is some comminution, your thoughts on buttressing this with a recon style plate that tends to be a little more malleable than, say, more of like an LCP or something kind of mini frag, but a little bit stronger. What are your thoughts on that? And have you or any of your colleagues or friends seen any recon plates fail in this application?
Well, yeah. So I've seen it fail in ways that were potentially predictable, some that weren't. I haven't seen one where there was, like you said, where there was if there's a read and it's over the apex. You rarely see it kind of fail that way. So I don't think it's the kind of the plate malleability as much as if you're just not holding it, especially going off the back. Those screws are resisting the coronal plane problem, but not as much the kind of shortening or rotation off the back. And so I've seen that happen where, this is, that's the trail of tears, right? When you're potentially either calling your partners or doing the total hip yourself and trying to figure out how to get it out. I've heard that story many times. But yeah, I think it's, I haven't seen it bend further, but I have seen it, first of all, I applied it in fractures that have failed the other way, kind of valgus in the end, strangely. And then I've seen it rotate off the back when we just don't have as good enough hold to support it off the back there.
Yeah, that makes sense.
All right. So if I can get my cursor back, we went a little bit over time, but hopefully everybody enjoyed it. In summary, we just want to kind of make sure that we got on the right page. I think, when I was thinking about this getting out, the young femoral neck fracture was this black box, one of the few black boxes I still had where if somebody called me and said, this is what we've got, I'd get a little bit, intimidated, right? And I think it doesn't have to be that intimidating, especially if you kind of take a methodical approach and get the advanced imaging for sure, study it. And then, like we were talking about, the jury's still out on a lot of these things. There are a lot of different approaches surgically, including closed manipulative reduction, right? But there are also advantages and disadvantages and thoughtful uses of implants that you can apply. And, making plans and getting this right, and not necessarily having to do it in a hurry, but getting it right is the advice I'd give to you, because they can be very thankful patients and long-standing hips that lots of people will tell you they didn't think you could save. So any parting thoughts, Jason?
No, it's been awesome. Really cool slides and case examples. I'm eager to try some more closed reductions and some plate applications. Yeah, thank you.
Jeff?
No, I mean, I echo what you said. It's this is an intimidating injury, no matter how far you get into your practice, and it's because of the ramifications. So you just have to be methodical, and there's lots of different ways to skin this cat. You just have to find make sure that you emphasize reduction above everything else, and that's really all you can do.
Totally agree. Be prepared for a little extra time too, but bring everything you can, including some assistance. All right. Well, thanks a lot, you guys. This was a pleasure to put together with you, and to the audience and anybody listening to the recording eventually, thanks for your time. I know this is kind of a webinar sort of thing. I haven't seen any questions come around, but I may not have been checking hard enough. Any questions at all? Well, all right. I don't see anything else coming up. Thanks a lot, you guys. It's been a pleasure.